بحب وجه تحياتي لكل الدكاترة من سوريا ومن أمريكا هون. هاي أول مرة أنا بعمل هيك شيء يعني لأطباء سوريين. بس بدكم ما تواخذوني لأن ما رح أحكي بالعربي بالمحاضرة، لأن أنا يعني تقريبا كل المصطلحات العربية اللي كنت تعلمتها بكلية الطب نسيتها، لأن الموضوع له زمان كتير. يمكن وقت اللي تخرجت كلكم ما كنتوا ولدانين. فإلي هلا تقريبا 40 سنة طالع من سوريا، وبعدين ما رجعت حتى اشتغل بالطب بسوريا، فمصطلحاتي وكل شيء بعقلي مركب بلغة مختلفة. فبدكم ما تواخذوني لأن ما رح أحكي بالعربي. بس إذا في شيء تحسوا إنه بحاجة لتوضيح، بلال بيساعدني، وأنا بحاول إني وقف كمان ببذل جهد. خليني أول شيء let me introduce myself. They call me here Sam. لأن ما بيعرفوا يلفظوا اسمي مظبوط، فقلت لهم okay, Sam would be fine. I am the director of research department at this organization here. It's a community-based organization that is the largest cancer care delivery system in the state of Arkansas. We have 6 cancer centers and 12 other clinics and locations to provide care to cancer patients. These are my specialties, and I am an active member at the American Society of Clinical Oncology and the rising chair for the ASCO-COPI certification program. This is an important committee that I have worked with for the last 10 years, and next year I will be the chair. Usually the way we function, we give practices certification the same way that we give individuals board certification for their knowledge. Here we give them for their adherence to the quality of care, safe administration of chemotherapy, and pursuit of improvement of the service that they provide to the patients. I have been also involved locally with our Arkansas Cancer Coalition, and I was the board member for 6 years. I stepped down last year because I took this job here at Carti, and after staying for 20 years at the University of Arkansas, I was there the chair of the hematology oncology program, and also I led the fellowship program for 12 years. I did these trainings that you see here, fellowship residencies. I switched from my early passion in endocrinology to intensive care at some point when I was in France, but I did not really want to spend all my career there. And then 25 years ago, I came to the United States, and I decided to do hematology oncology. The first question that I'm going to ask you, and you can see here the information about the slido.com. For those of you who have a cell phone, please put that slido.com in your browser and log on, and then it will ask you to join. And once you have joined, it will ask you to use a code. This is the code, 835-318. This is the only code that you're going to use today. And the first question I'm going to ask you is the following. I am sitting for the USMLE exam in 1 year, 2 years, 3 years. You can answer now. All of them are accurate. There is no right or wrong answer here. You do whatever you want. I want to know exactly what your time frame is. In 2 years, 100%, and one only answered out of 3 people who joined. You see, I can see everything. So try to join if you can. That would be good for all of us, because that would make it more interactive. This was only to kind of train you at the use of the application, the Slido. And all of them are correct, as you can see. Let's do the first case, a 53-year-old postmenopausal woman with triple negative stage 3 right breast cancer, T2, N2, N0. Her past medical history is negative. Her workup showed no evidence of metastatic disease and normal ejection fraction. Which of the following would you recommend now? Surgery, then dose-dense chemotherapy, neoadjuvant chemotherapy with dose-dense chemotherapy, the same with pembrolizumab, or neoadjuvant radiation therapy. Then, all right. See, I expected that I would get that answer. you answered you want to give her neoadjuvant chemotherapy with dose-dense ACT or neoadjuvant chemotherapy with pembrolizumab. And the right answer at this point is this. Why I'm telling you that, actually the data from the study that led to this change in our standard of care were published about now more than a year ago. And anything, that's why I asked you the first question, when are you going to take your USMLE exam? If you are going to take the exam, for example, this year, it might not be on the exam, but next year definitely is going to be. And I want to here reveal a secret that is kind of, I would not tell you anything more about that, that I write board exams actually. And at this point, I'm not going to give you the questions, but I want to tell you all this is fair game, provided that it was published and was available more than 3 months before the exam. Can you believe that? So in the old days, we used to say anything that is more recent than 2 years, we would, less than 2 years, sorry, it would not be included. Now anything more than 3 months out, it's a fair game on the exam. Why? Because things are changing so quickly, and you know, if you treat somebody with the information of 2 years ago, you're so behind, and that's not the standard of care anymore. So where does this information come from? The Keynote 522 is the clinical trial that led to the approval of pembrolizumab in the neoadjuvant setting. And as you can see, this trial was designed for breast cancer patients with triple negative disease, age older than 18, newly diagnosed. And as you can see, for the T's, any T practically, if you have lymph node involvement, or else it has to be T2 and above. ECOG performance status has to be good, 0 to 1. And tissue sample was required, but not for enrollment. It was for enrollment on the study, but not to receive the treatment or anything else. It was only for stratification and exploratory analyses down the road. And the patients received carboplatin and Taxol, followed by AC or EC for 4 cycles, and pembrolizumab versus the same chemo regimen with placebo. And the pembrolizumab was continued after that in the adjuvant setting after surgery. And the patients received placebo otherwise. As you see, stratifications here was based on nodal status, tumor size, and carboplatin schedule, whether it was weekly or every 3 weeks. And this is one slide summary of all the results of this study. The PCR, pathologic complete responses, were definitely higher on the pembrolizumab, 64.8 versus 51 for the chemo alone. That was highly statistically significant. Furthermore, if you look at PCR by stage of disease, the higher the stage, the higher the gain. And if you look by lymph node involvement, the same story. It's another way to express that higher stage would lead to higher gain. However, looking at the PCR by PDL1, you realize that it doesn't matter whether it's high, intermediate, or low, basically, and even less than 1 with the CPS, and I will talk to you a little bit about CPS shortly. If it's low, even negative almost, the patients responded well. So that's why the FDA went ahead and approved this drug regardless of the PDL1 expression. Now, this might be a fair game also, fair game question for the board. They might tell you, for example, the CPS is this, and then you go ahead and you don't give them Pembro, and that would be wrong. Here, pre-planned analysis, you see at 18 months, I'm gonna show it to you on the next slide here. It's on the upper left-hand side. It's interim analysis number 2, IA2. You see the difference here in event-free survival. There is significant difference between the Pembro and the placebo arms. And then if you go to interim analysis 4, that was done at 36 months, this difference continues, persists, which tells you that this is true finding, that certain patients have benefited significantly from this drug. The overall survival, however, although numerically is still higher on the Pembro arm, it's not statistically significant. I want to highlight here the fact that the confidence interval includes the 1, and that might be also another question. I doubt that by the time you take the board in a year or 2 years, we'll have more mature data, and this information might change. So I want to caution you about the overall survival information. So here, in conclusion, 1 year of pembrolizumab is associated with 3-year event-free survival hazard ratio of 0.63, meaning we decreased the risk of recurrence by 37%, 7.7% improvement. With this difference have been similar with dose dense rather than Q3 weeks AC. And this is something that really nobody can answer at this point. And however, this is a new standard of care for eligible patients. Why is that so? Why second bullet? What does that mean? I want to go back to the schedule here and notice that the AC or EC were not given on every 2-week basis as it is standard of care at this point. They were given as every 3 weeks, and that is something that raised some eyebrows, and people who are very faithful and loyal to the dose dense. In reality, the benefit probably from 4 cycles of EC is the same or slightly better with dose dense, but the benefit from Pembro might supersede that and compensate for the loss of the benefit from the dose dense. All right, let's move on to the next one.
I have a question.
Yes.
For patients who have, I know like there's a study about triple negative breast cancer, like patients has lymph node negative, we don't have to add carboplatin. However, in this trial, they didn't differentiate. So for me now, when I have a triple negative breast cancer, if I have a lymph node negative, for example, if she's T2 or T3, I'm actually do 522, but I'm dropping the carboplatin. What do you think?
I think that's very reasonable. And
okay.
I don't have a slide. I have done an entire presentation about carboplatin not too long ago. The bottom line is that we truly don't know the role of carboplatin at this point. We know that it increases the rate of pathologic complete response. However, you have the German study and you have the American study actually that both have used carboplatin in the neoadjuvant setting. The German study showed improvement of pathologic complete response and event-free survival, while the American study didn't show any improvement of event-free survival, although the improvement of PCR was there. The point is that we truly don't know the place of carboplatin yet. That's the
in my current practice, I only added if the lymph node is negative right now.
Right. You add it if the lymph node is positive, you mean?
Yep. Right.
Yeah. I do the same, honestly. And also I look at the patients. I have patients who are older patients. You add more toxicity with it. You need to add some. If you do Taxol by itself, you can probably get by without any growth factor support, actually. While if you do the carboplatin, it becomes a necessity, and you have to add these daily injections because Neulasta is not going to work in the setting of weekly treatment, right? So you end up having, more, cumbersome regimen as opposed to the Taxol that the patients come, they get their treatment weekly and they go. I agree with you, though.
Thank you.
Any other questions? Let's do this one. A 61-year-old woman had right mastectomy and sentinel lymph node biopsy for clinical stage 2, triple negative invasive ductal, received neoadjuvant chemotherapy, dose dense AC, 4 cycles, weekly Taxol times 12. Final pathology showed residual invasive cancer, 30 millimeter in the breast, sentinel lymph node were negative. What would you recommend next? Capecitabine 6-8, cytokeratin 5-6, EGFR testing, carboplatin gem, no additional therapy. Okay. I think, the we are moving a little bit away from this paradigm, and the answer actually is not A, is B, and I will tell you why. Now, certainly all of you used, those who voted, used the data that came from CREATE-X trial for adjuvant capecitabine after neoadjuvant chemotherapy with residual tumor. The study was designed to enroll patients who had HER2 negative, stage 1 through 3B breast cancer, with residual invasive breast cancer after neoadjuvant chemotherapy and no prior treatment with oral 5-FU. Notice that this study enrolled patients with hormone receptor positive and hormone receptor negative disease. So you have the hormone receptor positive and the triple negative patients. And those patients received capecitabine or control. It was a larger study. And when you look at the 5-year disease-free survival and overall survival, the capecitabine group was definitely superior to the control group. And the hazard ratio was 0.7 at 5 years, 0.6. 0 and at 10, for the overall survival and for the disease-free survival respectively. And the p-values were also significant. So why am I saying no? Let's go back here and see what happened. If you look at this panel, it's a little bit complicated, but I will guide you through it. The first to the left, the top is disease-free survival, the bottom is overall survival. So if you go like the top panels are disease-free survivals, the bottoms are overall survivals. The left-hand side, you have the entire group, and you see that was different, favoring capecitabine and statistically significant. The second panel, the set of panels, is the triple negative, and the last one to the right hand is the hormone receptor positive. You notice that really was what is driving the results, the data on this study is the triple negative, then not the hormone receptor positive. And that was a subset analysis. And based on that, the FDA approved capecitabine as an adjuvant treatment for patients with residual tumor after neoadjuvant chemotherapy in triple negative only, not in hormone receptor positive patients. Now, that's good. We had a year ago this study from the Spanish group that was presented at San Antonio, actually 3 years ago, 2018. As you can see, this is only triple negative breast cancer patients who were enrolled on this study. And as you can see, the T's go from T1C to T3. It can be N0 if you have like T3 or N2, N3A, and so on. But all of them had M0, meaning no metastatic disease. And all those patients should have had either a prior standard neo or adjuvant chemotherapy. The neoadjuvant component was only 25% of the total population of this study. And they should have received the anthracycline plus minus taxanes, and they had surgery with free margins. And there were some stratification factors here. And the most important one is based on the biological subtype of the cancer. They defined basal phenotype. They did not do the PAM50 to define that basal phenotype or genotype. They defined it phenotypically based on immunohistochemistry for cytokeratin 5 and 6 and or EGFR staining. So if you have either or both, you are basal. If you don't have any, then you are non-basal. And they stratified by lymph node involvement and prior chemotherapy, what type of chemo, and so on. And the patients went on to receive capecitabine or observation. They gave them, as it was recommended, 6 cycles of standard chemotherapy for the N0 and endpoint disease-free survival, other secondary endpoints, overall survival, subgroup analyses, safety, and biomarkers. So here, looking at the entire population of the study, as you can see, the event-free survival, disease-free survival here was 79.6% versus 76.8%, 3-point difference. And this was not statistically significant. And if you look at overall survival, it wasn't statistically significant at all. Actually, both groups practically survived at the same rates. So you would say, okay, no, capecitabine doesn't work. And, you know, probably you're right. Capecitabine may not work. This study, however, enrolled a similar number of the CREATE-X study, about 450 patients per arm. The only problem that we have with this study, it's that it's not post-neoadjuvant therapy. So this a group of people actually that were randomized might have, you know, when you do the neoadjuvant, you select all those who are sensitive to chemotherapy out, and you leave behind those who have residual disease that was not sensitive to chemotherapy. The question is, we had only 25% of this population that received neoadjuvant and was selected, therefore, for that thing. However, they didn't select those patients. I want to tell you that. They didn't select anybody. Everybody who had these treatments was offered the adjuvant capecitabine. So this was kind of one of the criticisms of the study that say, you know, it's not the same as the CREATE-X study. Granted, we can say, if any, this study might have included more chemosensitive patients, and therefore, because they were randomized equally to both arms, the ones that received the capecitabine should have responded even better. So, you know, we truly, there is no perfect study to answer these questions. Let's look at the subset analyses and see. The subgroup analyses actually that were done were related to basal, non-basal. And as you can see from disease-free survival, if you have basal phenotype, EGFR and or cytokeratin 5/6 positive, then practically no benefit whatsoever. But if you have non-basal, that's where you have a benefit from the chemotherapy. And this benefit is really significant. And likewise here, if you look at the overall survival, it's only positive in the group that has the non-basal markers. So that was statistically significant too, and the hazard ratio was 0.42, which means that you have improved here the chances of those patients to survive by about 58%. That's really significant. Now, in San Antonio this year, in 2021, this study was again trying to answer this question. Does everybody respond to capecitabine? Do we have better than capecitabine in this post-neoadjuvant setting in triple-negative breast cancer? And their hypothesis on the EA1131 study is that invasive disease-free survival with platinum is superior to invasive disease-free survival with capecitabine in basal subtype triple-negative breast cancer. So here they went on, you know, to tackle this problem head on. Let's face it, they said, and that's what they did. Patients were clinically stage 2 to 3 triple-negative breast cancer, and they were treated with here the same previously treated, you know, previously known treatments: neoadjuvant chemotherapy, taxane plus anthracycline, and here any pathologic positive lymph node were enrolled, but they have to have pathologic T1C, and T1C is any tumor greater than 10 millimeters and all the way to 20 millimeters. So you need to have some risk, basically. And you need to submit the tissue here for PAM50 analysis to you know, stratify those patients based on basal, non-basal subtype. So this is a more sophisticated way to address the issue of the basal subtype. And these are stratification factors: clinical stage at diagnosis, tumor diameter at surgery, planned platinum versus carboplatin versus cisplatin, anthracycline use, yes or no, and radiotherapy at any time. And we're going to move on here. And these are the data. I don't want to spend too much time on this because it's not going to be on the board this session, probably this round, but it will be next year, I'm telling you. A 3-year invasive disease-free survival according to subtype and treatment. Notice here the blue, the solid blue curve is the capecitabine in non-basal, and the dashed line or curve is the non-basal platinum. Both of them did way better than the basal, and the basal did dismally and compared to historical control, really the independent data and safety monitoring committee decided that this is futile and we should not continue this trial. Not only it discredited actually the hypothesis of the trial, platinums were not better than capecitabine, but also it highlighted again the difficulty that we have to tackle the basal subtype. And based on this study, many of my colleagues who deal with breast cancer day in and day out, at this point, we decide that probably we should not at this point offer capecitabine to everybody. Now, if you are taking the board today, capecitabine is the answer for any residual tumor that is larger than certain size, I would say 1 centimeter. But if you are taking it next year, it's going to be different. And that's what's going to be the answer. You have to get some markers to allow you to stratify or to classify your patient tumor, whether it's basal or non-basal type. Any questions? Okay. Should we continue?
دكتور مخول، إذا ما عندك مانع سؤال سريع. هلا بما إنه يعني من يعني trial 522 ومع البمبروليزوماب، يعني would you يعني بتعطي كابسايلبين بكل الأحوال if needed، ولا بما إنه الستدي تبع البمبروليزوماب ما كان فيها كابسايلبين، if you give pembrolizumab you do not give capecitabine إلا إذا طلعت ستدي ثاني combining both. وناقشنا هالسؤال كثير أنا والزملاء، بس يعني حابب أسمع رأيكم.
To tell you the truth, I personally feel that after I do the, by the way, if you look at the patients who have residual disease, the percentage of patients who have non-basal is the smallest. You have about 1/3 who would have non-basal and the rest would have basal. So once I have done my homework and established, for example, that the patients have non-basal and there is a chance that they would benefit from it, I would give it to them while I'm continuing the pembrolizumab. We had this discussion at the tumor board last week, indeed. And the schedule is you see the patients every 3 weeks. It's the same thing for the pembro. So you're not adding more complexity to their schedule, basically. They take the capecitabine at the dose that was specified by the trial, and I give them 6 to 8 cycles as it was recommended by the FDA. But here, notice that I'm giving it only to 1/3 of those who have residual disease, right? And so really, it's if we target our population, I think we can get more for our money, for our investment, more return on investment. And I would, the other ones who have basal only, I would continue the pembro without capecitabine. Any other questions? All right, let's do this one. 57-year-old woman had left mastectomy and sentinel lymph node biopsy for triple negative invasive ductal carcinoma, Ki-67 50%. The tumor 3.1 centimeter and one positive lymph node out of 3, no metastatic disease. Family history, mother with cancer died early, pancreatic cancer brother died early. Which will you order next? PET scan, radiation, genetic testing, tamoxifen. Excellent. So that is very good. This is what you need to order. The reason why, because you are going to treat this patient with something, and this something is olaparib. And if you don't know, if she doesn't have germline mutation, she would not qualify for it. And so it's so important. I did not give you this information. I gave you family history to suggest that this patient is at high risk to harbor germline mutation and the BRCA1 or 2 genes. And the Olympia study that is really the foundation at this point for our use of olaparib in the adjuvant setting was designed for those patients who have germline BRCA1 and 2 mutation, HER2 negative disease, and they have to have high risk primary. So it's really important to highlight that aspect of the high risk primary. They have to have completed definitive local treatment and more than 6 or equal to 6 cycles of neoadjuvant or adjuvant chemotherapy that would have contained anthracyclines and or taxanes and good performance status. As you can see, the trial enrolled 1,836 patients, and it was a very large trial. The patients, there was also, assessment after that for those who had neoadjuvant therapy, if they had residual cancer burden, and then stratification by stage 2 or 3 after adjuvant chemotherapy. So primary endpoint was invasive disease-free survival. Secondary endpoints was distant disease-free survival, overall survival, and safety. I want to take you to the next, the middle of this slide. As you can see, this patient enrolled both triple-negative breast cancer patients and hormone receptor-positive breast cancer patients. However, we know very well those who harbored the germline BRCA1, about 85 to 90%, depending on the studies, of them would have triple-negative breast cancer. The BRCA2, however, those patients might mimic the sporadic type of breast cancer. What does that mean? That means if you have BRCA2, there is a 60+% probability that you'd have hormone receptor positive disease, and also about 30+% to have either triple negative or hormone receptor positive and negative, or negative, I should say, with HER2 positive disease. So the same breakdowns that we see in sporadic, we see it in the BRCA2, but the BRCA1, most of them are triple negative. And as a result of that, because BRCA1 is slightly more common than BRCA2, most of those patients had triple negative breast cancer, as you can see. 1,500 of them, 325 had hormone receptor positive. But notice, it's really important here when you are applying this trial to your patients to know exactly what went on here in the selection of the patients. Those who had neoadjuvant chemotherapy, they should not have achieved pathologic complete response. So those with residual, you give them then that olaparib thing, or you put them on the study potentially. And here the CPS is different from the CPS that we will talk about for the detection of PD-L1. It's here to assess from a clinical standpoint the strength of the estrogen receptor positivity. And the CPS plus EG score, if it has to be 3 or more in order to consider those patients at higher risk. And the other last thing is the number of lymph nodes. They should have had 4 lymph nodes or more. And those patients were randomized to receive olaparib 300 milligram twice a day for 1 year, 921 patients versus placebo. And these are the results. The invasive disease-free survival was definitely better on the olaparib arm, 85.9% versus 77.1% at 36 months. And that was highly statistically significant with a hazard ratio of 0.58, which means we decreased the risk of recurrence by 42%. And that is a net improvement in invasive disease-free survival by 8.8%. And again here, distant disease-free survival was also positive, favoring the olaparib arm with 7.1% net improvement. And if you look at different groups to see who benefited, who didn't benefit, and this is what we call the forest plot. It's extremely common here, the way that we express the results of the clinical trials to see if any subset did not benefit from, for example, from the treatment, or even might be hurt by the treatment. So usually the treatments are aligned in a way to be like the numbers higher than 1 would favor the placebo. The numbers lower than 1 would favor the experimental drug, and here olaparib in our case. And as you that is for hazard ratios, by the way. And the line that you see here is it gives you the confidence interval. So any confidence interval that crosses the unity line tells you this is not statistically significant. And also the square, it gives you the volume, the size of the evidence, the strength of the evidence. And as you can see, depending, some groups are small, they will have small square and wider confidence interval. Some groups are bigger and they have therefore larger squares and narrower confidence interval. The reason why I'm explaining that to you, because it's really extremely important to realize that for the hormone receptor positive group, it was a small square and the confidence interval was so wide, crossing the unity line, and it's no surprise, it wasn't statistically significant. So this is really an extremely important point, but this analysis was not here designed to prove that olaparib would work in hormone receptor positive in a statistically significant way. It was designed only to see if the hormone receptor positive would have fallen on the other side. So what does that mean? That means if I could enroll 700 patients with hormone receptor positive on each arm, probably the confidence interval would have been narrower, and the benefit might not be as robust, as striking as in the triple negative, yet it would have been probably better. And it has fallen certainly below the unity line for hazard ratio, which tells us that it is possible that this is really beneficial, and albeit not necessarily as much as in the triple negative breast cancer patients. And here, that is very new. That was presented at San Antonio 2021. The point here is does olaparib add more toxicity to the patients? And apparently the most important toxicity was fatigue, and these PRO, patient-reported outcomes. You're going to hear about those more and more. And the pre-specified clinically meaningful difference was said to be at 3 points. And as you notice, anything negative, that tells us that olaparib is worse than placebo. However, we have not reached the -3. What we reach is -1.3, but because the entire study was really big, it was statistically significant, yet not the clinically significant. Why 3, for example? How did we determine that? These are the FACIT fatigue. These are standardized, validated surveys that were, were found based on other studies and different types of cancers, different types of treatments, and so on. And the idea was that when patients have 3 points and more, that becomes really in their lives significant in determining their level of activity and so on and so forth. And they found out from these previous studies that anything less than 3, the patients felt tired, but were able to manage. They were able to get up and do their things, probably went from ECOG 0 to ECOG 1. And that's how we validated these studies. So we know upfront from the get-go that 3 points and more would be bad. So although statistically significant, clinically is not. I think this is the last slide in this case. Any discussion point, any questions about it?
Yes, please. So, so when are you getting germline genetic testing on triple negative breast cancer with the early stage?
That is an excellent question. And I think this is going to be a fair game at the board, by the way, guys. At this point in our institution, we do it on everybody. Everybody with a triple negative breast cancer, we do germline testing. Now, notice, I said everybody germline. Now, what do you do with the tumor? We go ahead and send the tumor for somatic mutation in the tumor itself. And so we have now collaborating laboratories that can do both for us. So we send the blood sample for the germline, and if it is positive, it's positive, then that's it. If not, we go ahead and send the tumor. It's much easier to do it from the blood than from the tumor, and it's less costly and so on and so forth. So that's how we proceed. But we try to, why is that so? Because we do have data to support the use of olaparib too in those patients who have somatic mutation, believe it or not. But at this point, this case was designed only for the germline mutation.
Yes,
but we do it for everybody now, to answer your question.
Sounds good. And so what do you do if a patient has a germline BRCA mutation and received Pembro in the neoadjuvant setting? So are you given Pembro with olaparib?
Yes.
Adjuvantly?
Mm-hmm. The question that we had a similar case actually to what you're describing, and the question came up, should we give that patient with residual tumor now? You see, they have to have something high risk stuff. The patient had residual tumor, triple negative, BRCA1, and then received the Pembro. Do you do the capecitabine? Do you do the olaparib? And do you do the continuing the pembrolizumab? And nobody has really an answer to this question. I doubt that they would ask you this question on the board, honestly. I write board questions and I review board questions. I want to tell you that. If this comes my way for this cycle, I'm going to reject this question. It's not, in my opinion, ready for prime time. This is not, at this point, we don't know. It's possible that putting everything together, you might improve the outcome. It's possible that you might hurt the patients without improving the outcome. And so we need this. These are always, this is the cutting edge where science is today. And we need to either have studies or kind of analyze data from previously existing studies, or do real world data analyses. And that is something that is gaining momentum, actually, as we speak about, because the possibility now to collect data from real patients and then analyze them retrospectively and see, when you have large number of patients, it becomes meaningful, and you might not need to put together a prospective clinical trial for that. But we don't have the answer to this question.
Thank you.
Any other questions about this case? All right, let's move on to the next one. Ready? Here you go. 71-year-old woman has had the right breast lump and for 3 months, measuring 3.6 centimeter, no palpable lymph nodes. Core-needle biopsy showed invasive ductal, ERPR positive, HER2 positive, Ki67, 55%, past medical history positive for type 2 diabetes with severe neuropathy. She would like to have breast conservation surgery. What would you recommend? Trastuzumab, pertuzumab, paclitaxel, TDM1, or with anastrozole or TDM1. Okay, excellent. That's really, I think somebody has read the memo apparently, and the first memo, you did not get the second one. The answer, believe it or not, is this one. Let me tell you why. Everything you need to know is on this slide. The ADAPT trial, it's a neoadjuvant preoperative TDM1 plus minus endocrine therapy. And you see on the left-hand side of this slide, the randomization to TDM1, 3.6 milligram per kilo, or the same with endocrine therapy, or trastuzumab plus endocrine therapy. And all this treatment was continued for 12 weeks. Patients went after that to surgery, and the endpoint was pathologic complete response. And you have the answer here. TDM1 by itself was able to achieve pathologic complete response in 41% of the patients. TDM1 plus ET, which is here endocrine therapy, 41.5. So really no difference whatsoever. And the trastuzumab ET was 15%. It was way below the TDM1 arms. So the answer here is truly doing TDM1 probably is all what you need to do in this patient. She had neuropathy. She did not want to have the Taxol. We know very well from the trials that compared TDM1 to Herceptin paclitaxel that neuropathy is the main problem with Taxol, and TDM1 had different side effects, but it wasn't, neuropathy wasn't the biggest one of those. And adding endocrine therapy probably might not hurt the patient, but it might add few side effects that you might not need during that phase. So you will do it down the road, right? But at this point, TDM1 is the answer. Any questions about this case? And by the way, this is not the new information, by the way. So yeah, it is a fair game for the board. They might ask you this question. I don't know. Let's move on to the next one. Ready? Here you go. 59-year-old woman with progression of metastatic triple-negative breast cancer in the bones and lungs. Symptoms had pelvic bone pain, but no fracture. She had Pembro and paclitaxel for 22 months and had initially responded well to the treatment. In addition to Zometa, which treatment would you recommend? Sacituzumab govitecan, Carboplatin gem, Eribulin, capecitabine. Okay, it's two people dared, and here we have sacituzumab govitecan and capecitabine, and the answer is sacituzumab govitecan, sorry, versus capecitabine. This is the ASCENT trial. This is an important trial, and it's really important for us to know about that. This is an international randomized open-label phase 3 trial. Patients with metastatic triple-negative breast cancer and 2 prior chemotherapy or more. There was no upper limit. You could have had 10 of them. Could include also, within 12 progressive disease within 12 months from neoadjuvant or adjuvant therapy. So this group of patients is considered by everybody as the worst type of cancer. You have received your neoadjuvant and your adjuvant, and here you go. 2 months later, you have progression. That tells us that those patients really have very resistant disease. A prior taxane, RECIST version 1.1 is the one that was used to decide that there was measurable disease. Brain metastasis, if stable more than 4 weeks, the patients were allowed, and ECOG performance status 0 to 1. 529 patients were enrolled, and sacituzumab govitecan was given at 10 milligram per kilo IV on days 1 and 8, and the comparator arm was physician's choice of single agent chemotherapy. Primary endpoint progression-free survival by blinded independent committee review in patients without brain mets, and secondary endpoints, usual stuff. The trial was halted early based on efficacy, and that was a recommendation, unanimous recommendation by the Data Safety and Monitoring Committee. And these are the results, and it's really striking. As you can see on this panel, the green is the curve for sacituzumab govitecan as compared to physician's choice of chemotherapy. Whether it's here for progression-free survival or overall survival. The overall survival was superior, almost doubled on this drug. And here you have the waterfall plot. As you can see, it's really very impressive, the responses and the number of patients, the magnitude of response and the number of patients who responded. And this is here on patients. The top panels were for patients without brain metastases, but when you include everybody, the full population is on the left-hand side, the bottom panel. As you can see, the progression-free survival was still fantastic, actually, on this analysis. Now, there is a second question here, but I would like to see if any reflection or comment on this case. Okay, now the question is, would you expect to see better or worse efficacy of sacituzumab govitecan in patients older than 65? And here the answers are better, worse, the same. Give me your opinion. That's okay, guys. This is something that That's the beauty of playing this way. Dive. Throw yourself in the water. All right, the same. Okay. Actually, it's surprising. It was surprising to me when these data were presented some time back. It was better. And these are the data. So when the patients were here without brain metastasis, and the data actually mimic, with brain metastasis mimic these data. So I'm not going to present those ones. You see, patients aged less than 65 years old, as you can see, median progression-free survival was 4.6. Patients older than 65 years old, median progression-free survival 7.1, compared to certainly the control arm, which is chemotherapy of the physician choice. So that really was significant, wasn't it? And here, when you look at toxicity, you might tell me, oh, but it probably is more toxic in older population. In reality, it wasn't more toxic. Even when you look at it, here, trial emergent adverse events, TEAE, were probably the same. But when you look at the ones that are here, the lower panel, if you look at it, any TRAE, trial-related AEs, you see that grade 3 or higher, actually they're lower in the older population. That was, again, a little bit surprising to me. And so basically, this drug is absolutely interesting, in my opinion. And, you can give it to patients older than 65 feeling good about it because it's not going to undermine their quality of life or cause them more toxicity. Any questions about this case? All right, let's move on to the next one. The 63-year-old woman with no diagnosis of metastatic triple-negative breast cancer. Scans showed mets in the bones and lungs, one lesion in the liver. Biopsy showed it's the same cancer. Which of the following will you order next? Nab-paclitaxel, sacituzumab, govitecan, PD-L1 of the liver, biopsy, CT DNA, circulating tumor DNA. So what would you give this patient? Now, remember, she was just diagnosed with metastatic breast cancer, the metastatic triple negative. Okay, good. Actually, the answer is PD-L1. And this is really an extremely important question because at this point, the standard of care for triple negative breast cancer, metastatic triple negative breast cancer patients is the inclusion of some form of immunotherapy. For a while, it was, between pembrolizumab and atezolizumab was taken off the market after the study that was conducted with Taxol, plain Taxol, the Impassion 131, did not show improvement, while the previous one, Impassion 130, had shown improvement, but the combination was with nab-paclitaxel. So based on these data, I think the company itself withdrew this drug off the market for triple negative first-line metastatic breast cancer patients. And the only one that was left was pembrolizumab or Keytruda. And these are the two studies. And you see the Impassion 130 used the SP142 equal or greater than 1%. And I want to tell you here a little bit about those things because it's really important to know that first, the type of antibody that was used in the assay is so important. And whenever you decide, for example, I'm going to do this molecule or this drug, you have to use the assay that was used on that clinical trial. And so the antibody for PD-L1, the SP142, was used, and you could have either stained the tumor cells or the immune cells. And here, as you can see, if you look down anti-PD-L1 immune cells positive. So for breast cancer, they used immune cells positive. For lung cancer, for example, they used either or. And for lung cancer, if my memory is correct, they used 10% for immune cells that would be positive, or 50% for tumor cells that would be positive. And you can go and do, in this case, a plain only immunotherapy. So this is really an important difference to consider when you are talking about how we can check for PD-L1 expression and so on. This is the study I was telling you initially, atezolizumab, nab-paclitaxel versus nab-paclitaxel placebo. Honestly, I was very enthusiastic about it. I'm one of the early adopters of any new treatment, and I start treating my patients this way. I thought that I had some success with this drug, and many of them stayed on it for a long period of time. However, I was disappointed when the results of the Impassion 131 that used the plain Taxol was negative, and we couldn't understand why. You know, there are always speculations about why a confirmatory trial fails to confirm the results of an earlier trial, but nevertheless, it's no longer available. Nobody would pay for it. I stopped using it. And I was left with the results of the Keynote 355 that used the CPS, and CPS is combined positive score more than or equal to 10%. And what does that mean? Here, the combined positive score, they stain the immune cells, they stain the lymphocytes, here we're talking about with monocytes, and we stain the tumor cells. And we count all the cells in that field, and we count also the cells that stain any stain, even weak stain with the anti-PD-L1, it will count. And then you count the cells that are positive and the cells that, the total number of cells, and you make a percentage out of that. And so CPS 10 or more is considered positive on this study. And eligibility was not much different, really. Usually patients who had older than 18 and had triple negative breast cancer first line, and so on and so forth. And there were stratifications and stuff like that. But they should not have had any active CNS metastases and no active autoimmune diseases. And the patients received pembro and chemotherapy. And here the chemotherapy was really variable. It could be a taxane, it could be a gemcitabine carboplatin. So here the designer of this study were, in my opinion, a little bit wiser or slicker. They were able to kind of squeeze different regimens in a way that would give a choice to the patients and their physicians. In case one regimen doesn't work, you can use the other one. If it doesn't work toxicity-wise, you still can use the pembro in addition to another regimen. And as you can see here, there was significant improvement in the percentage of patients who had progression-free survival. The improvement here at 18 months and 24 months was still statistically significant, while the median was also significant, 23 months versus 16. And hazard ratio was good, as you can see here, 0.73, and that was statistically significant. So let me go over a little bit the management of triple negative early stage breast cancer, and I will tell you how we manage it in our organization. This is the now, I would say, early stage breast cancer. I'm not going to talk about metastatic. I don't think we will have time, because unfortunately, and I'm sorry about that, I thought that I am limited to 1 hour. I promise you I can come back. I have the slides ready and I can do it anytime Bilal send me that order to show up, I will show up. So this is what we do. We do process actually the BRCA gene or other genes when we have triple negative breast cancer regardless at this point. We take certainly a strong, good detailed family history. And if you have strong family history, this is another layer of argument to support your, claim with insurances and what have you. And if the patients have a stage 1, we go ahead and send them for surgery. And after surgery, we decide based on the tumor size, the background of the patients, comorbidities, desires of the patients, so on and so forth, whether we are going to go with the second generation chemotherapy like docetaxel, carboplatin. Sometimes some of us replace the docetaxel by Taxol, carboplatin, but here we do the weekly instead of the every 3 weeks as it is in this schedule, or to go with a third generation chemotherapy, weekly Taxol followed by dose-dense AC, or TAC, which is a combination of docetaxel, adriamycin, cyclophosphamide for 6 cycles. I'm not here wedded to any of those, and I could do any of them depending on the circumstances. So that's why I put those here as an acceptable regimens. None of them is my favorite, let's put it this way, and I do any one of them potentially. And we send the patients for surveillance, and here surveillance is clinical. We don't do scans in early stage breast cancer patients. If you have a stage 2 or 3 clinically, we send the patients for neoadjuvant chemotherapy, and here our standard of care is weekly Taxol followed by dose-dense AC, plus minus ICI here, depending on the circumstances. And we add carboplatin, as I answered earlier, to patients who have really high risk and can handle the toxicity of carboplatin. If you achieve PCR, now you're supposed to give the patients ICI. We don't really feel that this is the way we should go. We have question mark on this, and I can discuss that with you next time. The non-PCR patients, we used to offer them capecitabine, and those who have BRCA1 or 2 positive mutation, we give them olaparib, and sometimes depending if they have really high risk residual RCB3, for example, I offer also capecitabine followed by olaparib to those patients. In terms of surveillance, those patients would have a clinical surveillance every 3 months, and then we do scans. And here, this is a controversial issue. I do scans. Many of my colleagues do too. Here in our local environment in Arkansas, many of us do scans, while in certain circumstances, some other doctors in different local environment, they might not do it. There is no right or wrong answer about that, but honestly, I feel strongly about that personally. For a disease that is likely to recur within 3 to 5 years, as opposed to the hormone receptor positive, where where natural history can extend all the way to 25 years, in my opinion, it's worthwhile investing few scans to see if we can detect these recurrences early so we can treat the patients appropriately with aggressive treatment and put them back in remission. Now, this is what we were doing up until recently. Now, I want to show you here this information about the prognostic value of tumor infiltrating lymphocytes in young triple-negative breast cancer patients not receiving chemotherapy. And notice here, yes.
عفوا دكتور، بس لانه انتقلنا سلايد ثاني. هلا بالصفحه اللي قبلها في عندنا هون عم تحكي حضرتك عن الايرلي ستيج. هلا الستيج 1 عم تقول فورا سيرجري، بس ستيج 2 اور 3 نيو ادجفنت على طول، اللي لازم ناخذ الشروط نفسها اذا كان هير 2 بوزيتيف او كان تريبل نيجاتيف او هيك شيء.
No, these are all of them triple negative.
تريبل تمام.
Yeah, that's why if you notice, most of our discussion today was on the triple negative. So I wanted to give you an idea about how we treat triple negative in our institution.
تمام، شكرا.
That doesn't include the ER positive or hormone receptor positive or the HER2 positive disease. And we can do that next time. I have the next few of slides were specifically on the HER2, and I was going to give you another kind of rundown of our standard of care and how we do it.
Another quick question. Why did you say plus minus Pembro in the neoadjuvant setting here? Why not?
You know, that I'm telling you, up until now, this is what we've done. And like sometimes you present the patients with the data and they're not convinced. They're scared of the toxicity of immune checkpoint inhibitors. And, you know, in all honesty, to tell you the truth, side effects from pembrolizumab were minimal. Yet there were cases of severe pneumonitis, severe hepatitis, severe colitis, you know, hypophysitis, and so on and so forth. And I tell the patients, you know, if you put all these bad side effects together, probably they would not, I'm talking about the ones that can kill you, might not be more than 3-5%. And when they look at that, they tell me, but that's significant to me. And I say, okay, so what do you want to do? And some patients, they opt out. They say, no, I don't want to do it. I say, okay, you don't want to do it, you don't want to do it. So we make it optional. We don't, to our patients. And that's the reason why the plus minus. Certainly at some point before the approval, I have adopted that myself practically since ASCO of last year, but the approval happened, I think, 2-3 months later. So I came back from ASCO, I started using it. And but now it's really standard of care.
Sounds good. And what are your thoughts on CPS? So in the metastatic setting, I mean, clearly it's not a very good prognostic factors because we see very good, not very good, but at least there's some benefit in the neoadjuvant setting for CPS 0% in triple negative, but in the metastatic setting, not that much. So it's clearly PD-L1 CPS is not the best factor or prognostic factor to look at in terms of response to immunotherapy.
I agree.
So what are your thoughts on that?
If you remember, I presented the data from neoadjuvant study, and the CPS failed to discriminate between those patients who would respond versus those who wouldn't. So yes, I totally agree with you. And however, we have more data that were presented recently that showed the environment, the immune environment of early stage triple negative breast cancer is different from advanced metastatic triple negative. And unfortunately, I did not pull this slide, but I can bring it to you next time. Very beautiful work that showed the variability of the immune environment as you move from the early stage to the advanced stage. And therefore, you might think, yeah, probably in early stage it doesn't matter, but it might matter as we go along, toward the advanced stage. The other thing that was nice about that work, another work that was presented at San Antonio, is the immune environment is variable from one organ to the next, believe it or not. If you have metastases to the ovaries, for example, the immune environment is favorable. If you go to the brain and I think to the lung, the immune environment is not very good for immune checkpoint inhibitors to work on these things. So in my opinion, we are understanding a little bit more about how the cancer, the primary, as well as the metastases are interacting with the immune system and the local environment. And I always believe that in order for a cancer cell that landed in a distant organ or distant tissue, in order for it to be able to survive and create the metastases, it has to negotiate its right to exist, get some license from that microenvironment to grow. And that license not only would involve fibroblasts and monocytes and lymphocytes or whatever, it is the combined effect of all those. And sometimes, and most of the time, fortunately, they don't get that license, and some of them die in the new environment, and some of them reach a kind of equilibrium, as we call it. They don't die, but they did not receive the license to grow, and they keep dormant until something changes in that microenvironment. And we have data to support that now. This is not something that we knew about, but honestly, I have written about that, and I suspected that this should be the case. Otherwise, how can you explain that you have one lesion that grows and the other one doesn't grow at all? It's there, but it's not growing. You see it and on the same treatment, and there must be something different. Either genomically, these different lesions have probably mutated differently, but also it's possible that the microenvironment was different. So that to go back to your question, to answer it, in my opinion, the immune environment of the early stage disease is different from metastatic disease. That might explain why the CPS failed. We need probably different parameter or different biomarker, different factor in order to stratify those patients between responders and non-responders.
Thank you.
All right.
دكتور مخول، بما انه انت حكيت عن السيرفيلانس، ما بعرف اذا حتحكي عليه مره ثانيه او لا، بس اسالك سؤال عن السيرفيلانس. هلا ولا بعدين؟
Yes, only ولا يهمك, go for it.
ماشي. بصراحه انا بالبريست كانسر اكثر شيء بخوفني السيرفيلانس، انه ما في ستاندرد سيرفيلانس بالسكانز. مثلا بالكولون كانسر دائما بنعمل، باللنج كانسر بنعمل، بالبريست كانسر هي الشغله الوحيده اللي ما فيها سيرفيلانس سكانز از like NCCN guidelines recommendations. فمثلا من كم اسبوع كان واحده من مرضاي endocrine receptor positive, hormone receptor positive, HER2 negative. She's was stage 3, 1.5 year into after treatments. وبعدين all of a sudden she did the CT chest for other reason, and she was found to have a lung nodule that was biopsied, and it's breast cancer. فما بعرف بس شو تعليقك يعني هلا غير التريبل نيجاتيف، يعني شو تعليق عموما على السيرفيلانس بالبريست كانسر؟ وانا بعرف كمان لما بلشنا الفيلوشيب كان في كثير من المرضى تبعاتك بيعملوا تيومر ماركرز، بس بعد بشكل عام لكل المرضى بالذات للايرلي ستيج او الكيورد بيشنتس. فما بعرف هلا كمان اذا في راي مختلف لك بالتيومر ماركرز انه تكون تدخل بالسيرفيلانس تبع بريست كانسر.
Yeah, this is really a very important question, Bilal. I think we might need to dedicate a little bit more time to it, but the short answer to it is the following. You know, ASCO and ABIM launched a campaign about 10 years ago. I think it was 2011 or 2012. It's called Choosing Wisely, about the use of imaging surveillance studies in early stage breast cancer. And what they did, they looked at all the available evidence from old studies that used old scans and old techniques to image patients with breast cancer. And they looked at the group of patients who had stage 1 and 2A. And these studies showed that it was rarely helpful in detecting the cancer early or changing the outcome of the management that was proposed by guidelines. And many of the patients who recurred their recurrence happened between scans. No matter how diligent you are, if you want to do these scans every month, that's impossible. A huge dose of radiation. And if you want to do it every 3 to 6 months and start phasing it out, especially in the hormone receptor positive, where after the first 2 years where you have a bump of recurrences, the curve is really flat, and the rate of recurrence per year up to 25 years is about 1 to 1.5% after 3-4 years. In these cases, what you are doing, if you were to be coherent, you have to screen those patients for 25 years. Are you going to do that? I don't think that it's reasonable considering the cumulative dose of radiation. Now, and the positivity, as I told you, was less than 0.5% in those patients too. And that was considered really clinically meaningless in terms of changing the management plan of 99.5% of the patients. Now, at the same time, studies came out that had tracked down the incidence of secondary cancers that happen as a result of exposure to radiation, repeated radiation. And these numbers were in the order of 1 to 1.5% of a population that received every 3 to 6 month scans for 10 to 15 years. When you look at that, you say, oh my God, I mean, the probability for me to find something that would help a patient making a diagnosis early of metastatic disease, less than 0.5%, and risk of giving that patient second cancer is 1 to 1.5%, what am I doing? And all the more that the secondary cancer is going to happen to those who would not benefit from it. So you're punishing patients who are otherwise cured for the sake of the 0.5% of patients that might be helped. Again, I say might be helped. So scans for stage 1 and 2, 2A in particular, breast cancer, all the more, again, I insist, all the more if they have hormone receptor positive, are now considered really inappropriate for those patients. And they don't get approved unless you have reason. If the patients come with symptoms, that's a different story. I'm talking about routine surveillance that you do for asymptomatic patients. Now, any stage higher than that, the jury is out. We don't have the data actually, whether it's for the ER positive or the triple negative. And I'm going to show you actually the next few slides here, food for thought. I don't think it's ready for prime time, but you realize that probably the story has more into it, and we need to be more, I would say diligent in looking at the data and trying to understand who would benefit, who wouldn't from any kind of treatment or surveillance, aggressive surveillance. So I don't know if that answer your question, but I think my practice at this point, anybody who has 1 and 2A, I don't order scans. The other ones, I do scans. I want to confess, even the hormone receptor positive, when they come to me with like 6, 7, 9 lymph nodes or T4 disease or stuff like that, that scares me to death, to tell you the truth. And even though I might get scanned at the beginning, it was negative and whatever, I still repeat it like a year, 6 months, then a year later, and something like that. Because those aggressive hormone receptor positive follow the pattern of the triple negative more so than the indolent, very low-key hormone receptor positive breast cancer. And
شكرا جزيلا. والتيومر ماركرز دكتور مخول إذا ما عندك مانع.
That's what I'm going to tell you about here.
Perfect. شكرا.
So these guys looked. This study by De Jong from the Netherlands looked, because the tumor markers are not really that good. Let me put it this way, meaning the CEA, CA15-3, CA2729, they're not good. We know very well now, and ASCO had issued guidelines about the use of tumor markers that truly they can be positive with no cancer, they can be negative while the patients might have cancer, they don't correlate to response to chemotherapy, and the scans might get to be negative while the tumor markers are not. So we could never use them to guide the treatment or make diagnoses in many cases. So they were abandoned, and at this point, we use them in special circumstances, but not for surveillance. Let me go back now and that prompted those folks to look at other things. And here they collected 481 cases of triple negative breast cancer patients, young, by the way, younger than 40, and they wanted to study tumor infiltrating lymphocytes in them. And they classified them based on the criteria that are now accepted by many people as way to classify them. Less than 30% is low. As you can see here below the Kaplan-Meier curves, you have the number of patients, and in red are the ones that are less than 30%, the majority of those patients, or half of them. And you have the 30% to 75 intermediate, and more or equal to 75, 1/4 of them is high. And when you look at survival probability with those patients, it's unbelievable that those patients did not receive any treatment, by the way. And all of them had, small tumors and no positive nodal disease. That's really an important thing. And when you look at those, the ones who had the low TILs really did not do well at all. I mean, look at that. It's practically at here looking at 15 years, the time is years. After 15 years, we have lost about, I would say, 40% of those patients. This is bad. And these are small tumors, no lymph node involvement. But if you belong to the majority, basically, of these triple negative breast cancer patients, the young, small tumors, node negative, you don't receive chemotherapy, that's bad. It's not good. The intermediate, even not good. After 15 years, we have lost 25% of those patients. The only group that is really holding its own is the group with the high TILs. And these are also results from the previous study and other study. Look at here, the similar group of patients. Here they looked, however, at patients who did not receive chemo, received chemo, more than 30% TILs. And as you can see, those who received chemo, invasive disease-free survival, 92% at 3 years. The same thing for those who received no chemo. These are 2 trials, granted, but at least I told you it's food for thought. It's not supposed to be to be applied tomorrow. This here, distant disease-free survival, 97%. Why is this difference of 5% here or 4% in this case? It's because we had local recurrences that invasive disease-free survival, they counted toward as an event, while they did not have distant disease-free survival events. So meaning those patients were able probably to be rescued, and that's why long-term survival was pretty not bad. And the same thing here for those ones who did not receive anything, 99% at 3 years. Based on this, we are debating this schema at this point in our institution. We take everybody the same way with small tumors to surgery. We study the TILs. If they have high TILs, we don't give them chemotherapy potentially. I'm not saying that we're going to do it. We're trying to see if we can, participate in any clinical trial that is trying to answer this question. And those who have TILs negative, basically, we say if it's more than 30 is positive, if it's less than 30 is negative, we give them chemotherapy and do surveillance on them. Alternatively, another way to deal with that, this is another schema that we are discussing too. Patients who have stage 1 T1 equal or less than 2 centimeters, we do the TILs on the biopsy. If it's positive, they go to surgery, go to surveillance. Those patients, I told you, the ones who are negative, they have very bad prognosis. It's similar to stage 2 and 3s. Many of those actually have 15-year disease-free survival at 60%. And those ones I just told you, some of them have it at 60% too. So, and this is the majority of the patients, by the way, with the T1. So the size of the tumor doesn't tell you the entire story. The TILs might be telling you something different. And those patients can go to neoadjuvant, model in this case, pathway. And if they achieve PCR, then the question is, should we give them really, in this case, immune checkpoint inhibitors if we have added it? And here, if they don't achieve the PCR, we can see if they have non-basal, we give them capecitabine. Otherwise, they would go and get the ICI. If they have BRCA1 and 2, we give them olaparib surveillance, as I told you. I'm going to stop here and take a few questions because I'm running out of time, honestly. I need to go to a different event.
دكتور عصام الله يعطيك الف عافيه والله. انا اسمي باسل اتاسي. انا عارف تذكرني عملت معك انترفيو بليتل روك 10 years ago with fellowship. فالله يعطيك العافيه والله، محاضره كثير ممتعه. وانا بدي اطلب من بلال اذا في مجال نحكي معك عشان تعطينا continuation ان شاء الله يعني على الميتاستاتيك ديزيز.
Absolutely, yeah, definitely. We can.
بس سؤال واحد. the only one case اللي هي شوي انا ما كثير يعني يمكن عندي تسألوا عليها، هي الكيس اللي حكيت عليها التريبل بوزيتيف ديزيز اللي اعطيت الانسر was neoadjuvant TDM1. ف this is يعني new standard or FDA approval on TDM1 يعني the main standard تبعها هي in metastatic disease or if you have adjuvant, if you have residual disease in HER2 positive. ف that's the only case وقتها كان المريض triple positive وعنده neuropathy. The answer was TDM1 only.
Right. Here it's kind of taking advantage of the information that we have now from clinical trials and apply it to situations where patients cannot take the standard treatment or they don't want to take the standard treatment. I have had many of those patients, and the alternative is to give them, for example, trastuzumab, pertuzumab, and endocrine therapy. There are data to support that as well. What we call chemo-free regimens. And although you might tell me, are they approved by the FDA? The drugs are approved by the FDA. The way that you use them is up to you. And not everything is going to be 100% approved by the FDA, the way that you might use it. And I don't think that the FDA would come after you if you use the TDM1 or the HP endocrine therapy option. I did not put it there because I did not want to complicate your life. I wanted you to really understand and know about the TDM1 from the ADAPT trial. It's really very fascinating trial, and it's possible down the road that would become standard of care at some point for certain patients. But in reality, to tell you the truth, it's possible that it will never make it to phase 3 study and big, population and stuff like that. So would you not use it if you have patients that would fit that design? I would.
Dr. Sam.
Yes.
Sorry, Basil, if you have a question, go ahead. I just want to comment about.
دكتور عصام إذا حاب تخليها للمحاضرة الجاية أو هلا سؤال سريع إنه patient with hormone receptor positive HER2 negative after they fail anti-CDK4 treatment and let's say they don't have PI3 kinase mutation, what's your best next choice? And one of the common things we see in practice, there's all the single agent chemotherapy, there's all this, you can do different things, Taxol, Abraxane, Gemcitabine, there's many things you can do. But in your practice, what do you usually do?
Metastatic hormone receptor positive breast cancer, second line or third line? Is that the question? Yeah. Honestly, at this point, this is a very tricky question to tell the truth. When they don't have PIK3CA mutation, I offer them mTOR with exemestane. And but most of the time, these patients have started already. Their first line is AI plus CDK4/6 inhibitor. Then the second line, there are studies that are ongoing now to see if the continuation of the CDK4/6 while changing the backbone of endocrine therapy, such as switching to the SERD, for example. That's what I do personally. If the insurance company allows me to continue the CDK4/6, I continue it with Faslodex. And then the third line, my third line would be either Alpelisib with AI or mTOR with exemestane, in this case AI. And now the fourth line would be something different. And to tell you the truth, at this point, these patients actually starting at the second line, we have clinical trials, we enroll them on clinical trials. And the most important, the most interesting, in my opinion, at this point, I can give you a lecture about that, specifically about that. I don't know if you've heard about the new drugs for hormone receptor positive breast cancer. There is an explosion of these drugs. In addition to the SERMs and the SERDs, selective estrogen receptor modulators and degraders, SERDs, we have now the SERCA and the PROTAC and the CERAN, and a plethora of drugs that work in completely different ways than the old ones. And all of them are interesting, and many of them now have reached phase 2 or 3 clinical trials, and we're opening these trials here. So the idea is that if you are addicted to the estrogen receptor or any receptor for that matter, HER2 or EGFR, whatever, you will remain addicted to that receptor for an extended period of time until you lose the expression of it. So trying to use different strategies that would tackle that pathway in different ways might always bring benefit to these patients. And the results from the new SERDs, for example, that are oral now are so impressive, to tell the truth. And I would love to present next time to you something on that, but that is truly just came out of the oven, as we say, and it's not probably approved yet, but it will be available certainly in few months, the oral SERDs. But the oral SERDs now, we have about 10 molecules on the market, and all of them are trying to find a niche for themselves in second or third line. And you will see many of them work in the setting of progression after Faslodex. And that is very exciting, to tell you the truth, to see that you can still sequence all these drugs and yet get some benefit to allow the patients to have control of their disease and better quality of life away from chemo. All this before even starting chemo. Long answer to short question. I'm sorry.
الله يعطيك العافيه. لا ممتاز والله. شكرا جزيلا دكتور عصام.
أهلا. Another question I heard.
دكتور عصام، معك ماريا. كومنت على نفس السؤال اللي سألك يا دكتور باسل بالنسبة للTDM1 للمريضة اللي صار عندها نيوروباثي. هلا بصراحة أنا I was little bit hesitant to do that لأنه عندي كتير مرضى لما بيصير عندهم residual disease وبنعطيهم TDM1 they really develop very bad neuropathy to the degree that sometimes I have to stop TDM1 and go back to HP although there is a residual disease. So what do you think about this neuropathy thing and TDM1 versus paclitaxel?
It's possible. It's really possible, and it happened to me too. However, on the trial that compared the two, the neuropathy from taxane was way superior to the, I mean, more frequent and more severe than the one from TDM1.
Awesome.
Yeah, so I think there is nothing wrong with what you're doing, honestly. And I do it the same way. I default after that to HP because that's the only way to finish their treatment.
And the second question that Dr. also Basil talked about the second line in metastatic. Honestly, in my practice, I usually, like when patients develop a progression of disease on Ibrance and Aramadex, I usually do a Guardant 360. And if I found ESR1 mutation, I just drop the AI and put Faslodex. So in your practice, you just add Faslodex or you measure this ESR1 mutation?
You know, I was going to talk, that is another part. I forgot to say that to Bilal about the markers. I started doing circulating tumor DNA in those patients, and I tried to capture the mutated.
The ESR.
Yeah, ESR. As you know, probably different studies have shown variable percentage of patients after AI who develop mutation of the estrogen receptor gene, and that the percentage varies between 25 to 40%, depending on the studies, by the way. So it is really very common, and you need to know about that. So the issue is truly here, what do you think is happening? Before that was, you know, common, and by the way, not every insurance is covering the circulating tumor DNA, by the way. So that makes it a little bit complicated. And if you have progression, which one is more likely to be the problem? At this point, we think it's the emergence of the estrogen receptor mutation, as opposed to other, you know, problems with the CDK4/6. At this point, with the CD4/6, also there is an idea that probably CDK7 might be involved in resistance, and there are drugs now, Temuraciclib it's called, that might be the answer to this question. So in the future, what we are going to do is more profiling of the either the tumor or the blood of the patients to see if we can tell which way we should go. Should we go with like estrogen receptor degrader, or one of the PROTAC are very interesting group of drugs because they're proteolysis targeting you know, drugs. What they do, they bind to the estrogen receptor and they recruit E3 or E2, which are the ligases that ubiquitinate the hormone receptor and degrade it entirely. So the estrogen receptor would disappear completely from these cells, and that leads to a complete halt of the activity of this receptor. So if this is the case, you might imagine many PROTACs are going to come to attack different parts of, and we are playing more now on that idea of trying to target use something as a delivery system, like for the antibody drug conjugates, as you saw with the sacituzumab govitecan. I mean, we're targeting here TROP2, and which is ubiquitous antigen on the surface of cancer cells, but we don't know exactly what does it do. What it does actually, it's a trophoblast cell surface antigen, hence the TROP2. And We don't know exactly what it does, but we know that once the antibody-drug conjugate latches on it, it injects the govitecan inside the cells, and then that starts killing cancer cells. So we are doing the same thing for the estrogen receptor. We send something that can stick to it and bring after that the ligases for ubiquitination and degradation by the proteasome. So we will see a lot of those using something that targets something that it doesn't do anything to it other than bringing, something to destroy it, or bringing a payload like chemotherapy and stuff like that. So.
Yeah. On the other side, actually, I got a phase 2 trial to my institution about when patients progress on Ibrance and AI. It's a phase 2 trial that we give 3 arms. It's with oncolytics, whether we give paclitaxel or paclitaxel with rheolysine, the oncovirus, neovirus. And the third arm will be paclitaxel, rheovirus, and avelumab. So PDL1. So we'll see what the result. But of course, it's very tough in patients. You're inducing like an inflammation.
Right. That's really, yeah. I mean, oncolytics are going to be extremely interesting too. We have a trial now for melanoma, though, not for breast cancer. I have done also several melanoma at UMS. They're very interesting, actually. And when they work, they're phenomenal. That's great. Any other questions? Okay, that's wonderful. Thank you guys for staying with me for the duration. I stopped sharing now and I am back here.
شكرا جزيلا دكتور مخول، والله يعطيك العافية. وصراحة يعني أنا شخصيا يعني مهما شكرتك وما بوفيك حقك أبدا. يعني والله كان شرف إنه تعلمت تحت إيدك.
Bilal, I want to tell you something about him. He's the most polite, most dedicated, and one of the smartest fellows I have trained. So I'm very proud of him too. But he still was able to do that for me. And I'm going to show you this caricature of me. Everybody loves it, Bilal. They think it's me. They find it funny, but also affectionate. And I said, okay, this is how I took it personally. So I appreciate really your invitation. I appreciate all the colleagues who joined us. And I hope that we'll be able to get along again another time and finish the rest of it.
شكرا جزيلا دكتور مخول. شكرا.
All right, guys. Good luck.
شكرا دكتور. شكرا.